Hello, everybody, and welcome to the badEM podcast. My name is Daniel Still, and I am your host. badEM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. Welcome to episode 5 of season 3, where I'm delighted to welcome Professor Salome Maswime, who is a giant in healthcare, both in South Africa and globally, as you will hear in the course of the episode. She has traversed clinical specialization, public and global health leadership roles, health systems strengthening, medical education, as well as medical regulation sectors, and seems to be just as well adapted to all of them in different ways. We talk about her career and how clinical work can relate to system change. We touch on some capacity building, especially related to her work as a clinical obstetrician and a gynaecologist, her global surgery work, and how context is key, especially in the African setting. Then we move on to her next career move, where she will be head of the medical school at Wits University. Without further ado, welcome to the show, Prof. Maswime. Would you mind starting us off by introducing yourself and sharing a bit about your professional background?
Thank you so much. Really excited to meet you this morning. So, Salome Maswime, Professor and Head of Global Surgery at the University of Cape Town, and also Director of the WHO Collaborating Center on Integrated Clinical Care. So I'm an obstetrician and gynecologist, qualified a few years ago in Wits University. Thereafter, I did my PhD and got an opportunity to go to Harvard to do my postdoc fellowship at the Massachusetts General Hospital, and then moved to Cape Town in 2019 as the founding head of global surgery. We established global surgery into a division and in the Department of Surgery. And then in the next month, I'll be starting at Wits University as the head of School of Clinical Medicine.
Wonderful. So that career has obviously gone from quite clinical to public health to systems development and now going back into health education. So lots of different broad themes there that we can touch on. Tell us about the work that the Division of Global Surgery has done. You started it from scratch and now it's developed into quite a meaningful operation.
So and I'll take a step back. So I did my PhD in obstetrics and gynae, looking at cesarean section outcomes and looking to reduce maternal morbidity and mortality from cesarean section related hemorrhage. And it was at that time that I really started to learn about this intersection between clinical medicine and public health, and learned about global health as well, looking at disparities across different countries and the type of interventions that one needed to look into. And that resulted in pioneering, I guess, stepping into this space, leading a global surgery division. But global surgery essentially is about strengthening surgical systems and improving surgical services and improving access to surgical care, built on this foundation that, more than 5 billion people in the world don't have access to safe and timely surgery when required. And what we were very proactive about was firstly developing a curriculum that looks at how to strengthen surgical systems and services. And through that, we've been able to establish an MSc, an MPH with specialization in global surgery, a PhD, and an executive leadership course in global surgery that's taught at the Graduate School of Business. But then we've got a whole research portfolio on strengthening surgical systems and services and looking at surgical epidemiology and a bit of improvement science and implementation science. And then lastly, global surgery in practice and what that looks like. So we've got what we call the Global Surgery in Action program, looking at how we look to strengthen systems and services through community engagement, quality improvement, policy engagement, and capacity building for healthcare workers.
Awesome. And in terms of the last thing you mentioned there, the capacity building for healthcare workers, what does that look like practically?
So we've established a number of programs over the years, and one of them is the Anesthesia Launchpad, where our team has partnered with different hospitals and provinces about training medical officers how to do safer surgery, really targeting medical officers in district hospitals who are not looking to become specialists, but want to provide safer surgical care. And the benefit of training them in safe anesthesia is that at the same time, they're the same people doing the cesarean sections and the surgeries. So it's a holistic approach to improving, for them to improve their surgical care of patients. We've also got another anesthesia program focusing on pediatric anesthesia, where we run a fellowship in Red Cross, where anesthetists can come spend a year with our team to basically learn pediatric anesthesia, to strengthen their knowledge of pediatric anesthesia and also to learn new skills. And then there are various other things that we've done, from cesarean section to burns care. And what you essentially get is people that are passionate about certain areas within the surgical domain, who are passionate about training healthcare workers to improve their skills.
And then the broader aspect of that plan is to obviously decentralize a specialist service, and district hospitals building a capacity to not have to make patients' healthcare journeys more winding and time consuming for everyone.
Yes, so it's two things. So the one is, we always emphasize that you need to understand the problem that you're trying to solve, and not bring a solution without, and cause a new problem at the same time. So, and that's why the partnerships matter, that we partner with, perhaps government or NGOs, because we need to spend some time trying to understand which problem are we trying to solve. In coming up with the capacity building innovation, what you want is to first spend enough time doing the research around what the real problem is, what the barriers are. And in understanding that, then you can determine whether that is the right intervention for that particular community or population. And then the other bit, of course, as you've mentioned, making surgery safer at the entry point, which would be district hospitals. And so, yes, in some instances, you want to decentralize care, because a lot of lives are lost, and a lot of people also live with, long-term disability and morbidity, because they are waiting to get to a tertiary hospital or a regional hospital. And so if we can make surgery safer at that level, then, you are improving surgical outcomes, you are improving quality of life, and you are reducing the trips that people often don't want to take to the city to get care.
Definitely. And to move that back onto the start of your career as a clinical obstetrician and gynecologist, I feel, well, from experience, obs and gynae is a field in which there's a lot of room for improvement in terms of doing the basics well. And that also differs very much depending on where you work. But I feel, compared to other specialities where the basics are often done very well at a GP or a medical officer level, for example, ortho, everybody knows how to put a pop on, and then the specialist stuff can be specialist stuff. Whereas with gynae, especially if the gynae is in proximity and is available, it's almost very easily just pushed onto the gynae, as opposed to there being a distinction with what needs to see a specialist and what doesn't need to see a specialist. What are your thoughts regarding that sentiment and the capacity building with obs and gynae in terms of GOPD? Waiting times are monstrous at the moment, and there are lots of patients waiting there for a Propel, which is a very simple procedure. And there are lots of people going for pap smear results there and things like that. So how do we build capacity there?
one of the problems, as you've mentioned, there's a lot of task shifting and task sharing, obstetrics and gynae. Anyone can be brought to do a cesarean section, but not everyone can manage the complications for a cesarean section. And how do you decide who is safe to do certain cesarean sections and who isn't? But also, tertiary and regional hospitals also get overloaded with cases that can be done at lower levels of care. And then there's also poor communication in terms of the different levels of care, because, often the specialists want to sit in one, even conferences, you've got the specialist conferences and then you've got
everybody else.
and yet you're all treating the same woman at the end of the day. So how do we break down those silos? But rightfully, as you've said, our discipline, well, it's two things. On one hand, from a health systems strengthening perspective, I think obstetrics and gynae has done relatively well, better than many other fields, because you get taught about community obstetrics very early on, and you get taught about obs and gynae care from a health systems perspective. And I think the obstetricians come out with that knowledge and understanding mortality rates, perinatal mortality rates, and all of that. But at the same time, obstetricians and gynecologists have no control, because a lot of things are done by generalists that should be done by specialists. But I think we need to rethink all of that. And I think obstetricians are starting to gain more interest in global surgery, for example, and global health, and looking at a more system strengthening approach than a pure clinical strengthening, capacity building model.
Yeah, I think that one thing that as with obs and gynae, that is to their advantage is that the child and maternal mortality is a very measured and documented metric that people very much care about. So it does gain some investment, I think. And then, do you think that obstetrics and gynecology should be separate fields? This is an age-old question that people have been talking about for a long time, but it seems to be in a sort of more siloed versus less siloed debate also.
I personally don't think so, because, yes, whilst they're separate fields, but they intersect very nicely together. And you want a well-rounded maternal women's health specialist. And I think that works really well. But we know now they've increased the years of training from 4 years to 5 years in South Africa, and all of those changes. So I don't see that, you'd want an obstetrician who trains for 5 years and a gynecologist who trains for 5 years. Yeah, I would push towards keeping them together. But in practice, in reality, people choose what they want to be. I call myself an obstetrician because I found my passion was really in the labor ward with maternal health. But I still do a lot of women's related health and reproductive health. But as a practicing clinician, obstetrics was the part that got me really excited.
And then sort of drifting back to your public health work, a lot of the people I've spoken to on this podcast have done clinical medicine and global or public health, and you especially have drifted very on a curve through all of it. And from a clinician's perspective, who sees a problem that they think that they can fix, so you mentioned earlier about you have to understand the problem. And if you have worked in a certain setting, in a certain context for a long time, there are certain problems that you get to understand very well. But then the solution either requires time or money or resources that aren't readily available to clinicians on the floor. And then those problems, if they are addressed by hospital managers or CEOs or clinical managers, there's a bit of a disconnect between them and the budget allocation. So it's And that is the big jump where these problems get lost. So what would your advice be to somebody who sees a problem and wants to start to fix it at a local context specific level?
And yeah, so rightly what you've said, the disconnect between public health and the clinical disciplines, and that has gone on for so long. And what I saw as a specialist in a clinical discipline was that we assumed someone was solving our problems. Yeah, there are people doing that, but they don't understand what we are looking for. And until we start engaging with them, we not one person is doing on one side of the system something else and we are expecting something else, but the patients end up with us. When the system is broken, the patients are the ones who suffer and they end up in our hands. So for me, my conviction was to get into the health system and realize that there was also something powerful about being a clinician who also understands health system strengthening and is contributing on a policy level, on a quality improvement level, on a community engagement level. But to get there, you need to equip yourself in certain skills as well. And some have gone on to do MPHs to get the skills. Others have done short courses. We offer the leadership course, on surgical leadership for people who are precisely trying to solve the system's issues. And I really believe that clinicians can contribute to health system strengthening and play an important role in it. But we also need to equip ourselves because it's a different language altogether. And over the years, I've had to learn, it's a different anatomy, the anatomy of the health system, the physiology of the health system. You just have to see it as another discipline where you need to equip yourself to know how to bring solutions.
And the other way around, in terms of the public health people learning and engaging with the clinical world, that's obviously as important.
Yes, absolutely. And so if I can explain, the model that we have in global surgery, we teach surgeons about public health and we teach public health students about surgery. And it was a fascinating journey for us because we assumed the public health people had a good basic understanding of what happens within the clinical platforms or how clinical decisions are being made. And we found some of them had never, apart from their own experience, had never really engaged in surgical work or in the surgical theater. And so it was an important move for us to really develop a program that builds public health capacity in obstetrics and gynae, in surgery, in anesthesia care, for them to be able to make decisions and design programs that from a basis of having a clinical foundation. And even if you've done medicine and have a medical degree, but when you move into the public health space, you still need to be capacitated to design surgical programs because you would have spent your career being taught how to treat a patient and not how to treat a health system.
Yeah. I think it also depends a lot on when you make a move into public health, because a lot of people move quite early after studying and a lot of people move late after they're already head of department, for example. But there's a newly graduated doctor has a very different level of experience and understanding of a health system than someone who's been working in it for a long time as a clinician.
Absolutely. Yeah.
In terms of the African setting, you've obviously pioneered this global surgery division and in an African context. How does that differ from other contexts in terms of resources and obviously the starting point in terms of access to surgery, access to healthcare services is different at the beginning?
So when we started, So I think there were only two other programs. We all started around the same time in 2019. UCT, Stellenbosch, and WITS. And because of that, we could also work quite closely together in supporting each other in designing our programs. But there were a lot of established global surgery programs in high income countries. And they were mainly about sending high income students to Africa to get the experience of doing surgery in a low or middle income country. So understanding, doing surgery in resource constrained settings. But then you do your elective, you do your 1 year, and you go back to your setting, and you might never go back again. And then there were programs which were about research and more research focused, and then programs which were about sending more senior surgeons to our continent to teach surgical skills. Now, yes, going into a village to teach up surgical skills and all of that is capacity building, as we've mentioned, but doesn't touch on strengthening the surgical system. And then lastly, there was a group as well coming into Africa to work with policymakers, giving advice and all of that. But it's a very different context when I meet with my Minister of Health about problems that I am experiencing or that we are experiencing in this country, with the full context of the barriers and the resources and the finances and the politics. It's very different, someone who is in the system versus someone coming in from outside who won't understand all of that. And so we very much had to build a program that understood the context of what Africa needs and how African surgeons can contribute towards strengthening the system in addition to providing surgical care.
Yeah, thank you. Because it, like you said, dipping your toes from somewhere else without a lifelong career worth of experiential knowledge, it's not quite the same. And then to move on to the work that you've done with the Health Systems Trust, touch on the work that you've done with them, because I've been exploring some of their outputs, and it's wonderful databases and research work that they do. What exactly did you do with them?
So I served in the Health Systems Trust Board for the last 6 years. I also chaired their research committee, which is responsible for for two important publications in South Africa: the District Health Barometer and the South African Health Review, which is really publications that are used for decision making, not just by policymakers, but anyone really who's in the health systems space. And then last year, I served as the interim CEO. And that was during a transition where the former CEO had retired and they were in the process of appointing the next CEO. It was, quite an amazing time for me as well, fully stepping into a health system strengthening job as an executive for a few months. I learned a lot about health system strengthening from a public health perspective versus from an academic perspective, because here we teach students that you're hoping will go out there and implement change, and then being responsible for the change felt very different from, our academic experience. But personally, I learned a lot, but it was really working for an incredible organization, which has really contributed to our system strengthening in South Africa and beyond, and continues to do that. And it was a great privilege to support the organization in that way.
To backtrack a bit, for those who are not familiar with the Health Systems Trust, would you mind giving us a breakdown of the organization itself in terms of its history and purpose?
So the Health Systems Trust was started in 1992, and that was on the verge of the new South Africa being formed as an organization that was going to contribute to reinventing, healthcare and health systems for a new South Africa that was looking at having equity in terms of the health systems, and that was also going to not just contribute but also keep the government accountable as well in terms of strengthening health systems for the new South Africa. So it has a rich historical background in that, for example, Dr. Nkosazana Dlamini Zuma was on the board, or one of the founding board members when it started, and a lot of South Africans who have contributed to health system strengthening at some point have been in that board, exactly, or have held important roles in the executives or in the executive or as CEOs. So it's an organization that continues to take a step ahead, looking at the future of healthcare for this country, and continues to contribute in whichever way that they can.
Wonderful. Yeah, it's I would encourage everyone to go check out the website and what they put out, because it is very enlightening.
And then to move on to your next job as the head of the medical school at WITS.
So that's obviously back into education, into the medical education space. What are some of your ambitions there? And with your personal background with clinical medicine and public health, do you want to instill more of a broader picture and understanding of the health system and the context in which everyone works into medical students, as opposed to a purely clinical understanding, which is what I felt that has been the situation?
Yeah. So looking into the future, looking at WITS, and so the position itself, WITS has got 9 clinical departments and a lot of clinical divisions in those departments. But as the head of the School of Clinical Medicine, you're responsible for research and education across the different clinical disciplines, and also undergraduate and postgraduate education and research. So the MPPCH is one of the programs that I'll be responsible for, as well as all the specialist training as well. Looking at the future, I think we need to align with how medicine is evolving with the rest of the world. The future of medicine is interested in access, and not just discoveries. And you want clinicians who will understand their context and the health system, and not only be taught about, best practice and the most advanced techniques and innovation within clinical care, but who are also able to strengthen health systems from a community perspective and also from a political perspective as well. So that would be my desire, to instill some of that, but also interesting shifts in teaching about innovation and leadership. So those are some of the things that I have in mind, but it's early days. So I don't want to commit too early to some of the things that I hope I will add to the school.
Yeah. One of the things that's always struck me is how people need to become very advanced, or not need. This is just the mostly done or trodden path. People need to become very specialized clinicians, often to become leaders in the healthcare space in terms of clinical specialization, and then HOD, and then academic output, etc. And there are not many people that have possibly good or leadership skills that are allowed to step in that space earlier on in their career. And on the opposite side, I think a lot of the specialist clinicians don't have very good leadership skills, but they are forced into those roles because they are in the positions that they are. Do you think that that is going to change ever?
I'm hoping it will change. I'm certainly hoping. And I think if we really look at how clinical education has been, and I like to say it's been a bit patriarchal in the way that it's been taught. often teaching by bullying, by humiliation. And because of that, you have people who are sitting in leadership, not leading
Yeah,
properly,
exactly.
and really not valuing the talent and the skills that come from the more junior colleagues. And because of that, that's why you've got this system where you have to be a professor before you come up with a new idea. And the world is changing. You've got innovators who are young, who are junior, but they might just have the right solutions for what we need to do. And if we start to incorporate leadership training early, you start bringing those competencies early so that those who are going to be future leaders are already using principles of leadership, like transformative leadership, for example. They learn about those early and they don't go into, what we found ourselves in.
And then the last formal question: if you had a magic wand and anything that you wished for could be materialized in South African healthcare tomorrow, what would that be?
Sure. I would push for some sort of regulatory space around management, around clinical management and health systems leadership, because often the people that have to take account for poor outcomes are clinicians who actually did their best in providing the best level of care that they could under the circumstances they were in. And there isn't really a clear place within the framework of the country for accountability at leadership level. And that's where sometimes wrong decisions are made about the health system that actually could result in many lives lost, and preventable deaths that someone needs to, at the end of the day, be accountable for some of those decisions.
Yeah, and I think that accountability can go from a micro level from a clinical manager to a regional level to a national level to an international level. And I don't think leaders on whatever level are often they're not often exposed to the outcomes of the decisions that they made on a visceral level like clinicians are.
So I'm also vice chair of the Medical and Dental Board in the Health Professions Council of South Africa. And because of that, I now have a very vested interest in the regulatory space in South Africa. And I've been learning a lot as well in that space about not just regulating medical education, but also professional practice as well as professional conduct.
You must have seen some very interesting dynamics, clinical to power to political, play out in front of you.
Absolutely.
Awesome. Thanks so much for joining me and taking the time, and very privileged to have got to speak to you for a bit. And thanks for the podcast and good luck for the next role.
Thank you so much. Greatly appreciate it.
So that's all for this month. Thanks for listening to the episode. And thanks again to Prof Maswime for taking the time to be interviewed. As you heard in the interview, she's a very busy lady, and I feel very honored and privileged to have taken some of her time. To summarize, we spoke about global surgery and the complexities around capacity building, especially in an African setting, also in the context of her own field of Obs and Gynae. We spoke about the Health Systems Trust and the wonderful work that they do, and then we finished off by chatting about her new role as the head of the medical school at Wits, and her magic wand, which would be to fill the gap of a regulatory body for healthcare leaders in South Africa and to create accountability for the decisions that they make. And I would like to wish her all the best for her new job, and Wits are very lucky to be gaining her services. Be sure to rate, review, and subscribe on all of your favorite platforms, and to share the podcast with a friend or a colleague who might be interested. If If you'd like to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Follow us on Instagram and Facebook at Brave African Discussions and X or Blue Sky as badEM. Thanks for listening. See you next time. Bye bye.